Good evening, everybody. Welcome to another NIPMED tutorials. And today we'll be doing urinary tract infection. Urinary tract infection simply is a condition in which microorganisms, especially bacteria, they multiply and they persist in the genital urinary tract, causing symptoms or problem. Okay, so the epidemiology it affects all ages, but most commonly it affects women. Unless in the neonatal period when it mostly affects men. Reason because one, women have shorter urethra, which predisposes them to having a urinary tract infection. Secondly, the proximity with the urethra and the anus, and we know the rectum is colonized by normal bacterial flora. So these two places and these two reasons are why women are more prone to urinary tract infection than men. Now, etiology, most urinary tract infection is caused by bacteria, with Escherichia coli accounting for about 80 to 90%. Other causes are the Klebsiella, Proteus mirabilis, and Staphylococcus saprophyticus. Staphylococcus saprophyticus causes urinary tract infection in women of reproductive age, okay, women that are sexually active. So, you look at this, you realize that this is mostly the gram negatives that are the major cause of urinary tract infection. Now, there are three basic forms. We have acute pyelonephritis, we have cystitis, and we have asymptomatic bacteriuria. Now, the cystitis is the inflammation occurs within the bladder. So now we have signs of bladder irritation. So dysuria as pain upon urination, of urgency as decrease desire to urinate, frequency increase number of times person urinates, the suprapubic tenderness or suprapubic pain, there might be incontinence, malodorous urine. Usually there is no systemic manifestation. Okay. Now, acute pyelonephritis is when the interstitium has been involved in the inflammatory process. There's a very high risk of developing renal injury, acute renal failure. There's usually fever, abdominal pain, flank pain, malaise, diarrhea, vomiting, generalized symptoms of intoxication, and it could progress to a perinephric abscess. It could also progress to septicemia. It could progress to chronic pyelonephritis with renal scarring if not dealt with. All right. Asymptomatic bacteria usually occurs in women, and it's when we find growth of bacteria when we're doing urinalysis or urine MCS without there being any symptomatology. So there's no clinical manifestation of a urinary tract infection, and it's usually a benign process, and it not really cause any renal injury. So first thing that happens is contamination. The lower urinary tract, which is from the bladder down, gets contaminated with, let's say, Escherichia coli, since that's the major cause. It's contaminated, the bacteria then begins to multiply, and this is called colonization. So the pathogen grows and grows and grows and grows, and then it begins to what ascend, that's rising, and then it gets to the bladder. Within the bladder, it has special pili or fimbriae that allows it to attach to the bladder epithelium and penetrate it. Now, this process of attachment leads to activation of inflammatory cells, particularly neutrophils, that then go to the bladder and begin the inflammatory process. Now, in the case of urinary catheter that was passed, urinary catheters are introduced directly to the bladder. So, if the catheter wasn't passed in a sterile manner, or if it was contaminated, it would directly introduce bacteria into the bladder. Okay. Now, within the bladder, the bacteria begin to multiply and they start forming biofilms. Biofilms is just a constellation of bacteria around the particular surface. Okay, good. Now, when the inflammation begins within the bladder, we start having symptoms of cystitis. That is the dysuria, the suprapubic pain, the increased urgency that is actually urinate, and increased frequency, the amount of time person goes to urinate. Those are symptoms of bladder irritation and inflammation. Okay. Now, if the process isn't dealt with or isn't treated, the bacteria begins to ascend, especially once the number of bacteria is sufficient, it begins to ascend. Now they say that some bacterial toxins or the local inflammation there halt peristalsis, creating some form of urinary stasis, allowing the bacteria to continue its ascension. But when the bacteria gets to the renal pelvis, they can then go and infect the renal interstitium, leading to pyelonephritis, acute pyelonephritis. Now from there, they could spread into the blood and cause bacteremia or septicemia. Another way pyelonephritis can occur is if there's an ongoing bacteremia and via the renal vasculature, it goes into the kidneys. So there are two ways. One of them is an ascending urinary tract infection, and the second one is what? Hematogenous spread. Okay, those are the two common ways. But the most common is an ascending urinary tract infection. Alright. So when the renal pelvis has been inflamed on the renal parenchyma, neutrophils are going to come in, begin a whole process of inflammation, exudation, pain, and then the patient now has pyelonephritis. We're going to see the sign as fever, generalized intoxication, vomiting, diarrhea, costovertebral angle tenderness. And acute pyelonephritis can lead to or will lead to acute kidney injury if the inflammation isn't dealt with, because the inflammatory cascade will continue, leading to tubular obstruction and damage, leading to interstitial edema. So it has to be dealt with. So risk factors is female, but you said they have a short urethra. Second is vesico-urethral reflux. So normally the ureter opens inside the urinary bladder, and the ureter is oriented in which a certain length of the ureter enters the bladder. That in case in scenarios in which it is filling the bladder up, as the bladder is getting filled up, the urethra gets closed up by the bladder. So a scenario in which the length that is inserted into the bladder is short, they create some form of space, and when the bladder contracts, there's a reflux and also some voiding dysfunction. It could be in the scenario of a neurogenic bladder or some form of obstruction. All this leads to stasis of urine, and the stasis of urine allows bacteria to colonize the urine, and instrumentation, which is one of the most common causes of urinary tract infection, especially catheterization. Okay, then we have some anatomic abnormalities such as posterior urethral valve, or like we said, vesico-urethral reflux. Then pregnancy, because pregnancy, one, women have shorter urethra. Secondly, the presence of progesterone relaxes smooth muscles, and relaxation of the smooth muscles of the urinary tract leads to what? Stasis of what? Urine. So diagnosis is quite easy. First of all, is screening with urinalysis. So you do urinalysis to screen where you might see positive nitrites or positive leukocytes, or depending on the type of equipment you're using, if you also have the leukocyte esteries. Okay, so positive nitrite, either the nitrite producing bacteria, there might be an increased number of WBC, presence of leukocyte esteries, but absence of pyuria, that's leukocyte in urine, does not always rule out a UTI. So once a person urinates, you hold the sample. If you suspect a UTI, urine will look quite cloudy and you might see some form of sediments there. When you dip your urinalysis stick inside, you see sign that the nitrites is being produced by the bacteria, so be positive nitrites, be positive leukocytes or leukocyte esteries. Then you do a urine culture, and usually a midstream urine sample that you use, midstream. Okay, culture will show the bacteria, if it's Escherichia coli in the gram negative lactose fermenting, so it forms pink colonies of Macron-case agar. Okay, we'll show the organism that is there, and then you can go ahead and do the sensitivity. Then you can also do voiding cystourethrogram. This will help to assess for vesico-urethral reflux in children, ultrasounds of the kidney and urinary bladder. You know that later with urinary tract infection, or like due to maybe an obstruction, can lead to dilatation of the ureter, and that can lead to hydronephrosis. Another complication of pyelonephritis is a perinephric abscess. This can be shown on ultrasound or even on CT scan. Treatment. The first line treatment for UTI is trimethoprim-methoxazole, especially if it's a simple, uncomplicated urinary tract infection. Okay. Then we also have nitrofurantoin, ampicillin, amoxicillin, aminoglycosides. These are for more complicated ones, cephalosporins, and also we could use fluoroquinolones because fluoroquinolones are excreted in the urinary tract unchanged. But the first line treatment goes on is trimethoprim sulfamethoxazole, and you advise the person to drink a lot of fluid in order to pass off, to wash off or flush out the stasis that's occurring in the urinary tract. Encourage them to urinate often and increase dietary fiber. Prognosis is difficult to determine, but a simple, uncomplicated urinary tract infection has a simple prognosis, a good prognosis. Where there's renal scarring, like in the case of an acute pyelonephritis that is not treated properly, then leading to chronic pyelonephritis and then chronic renal insufficiency, that tends to have a poor or bad prognosis. Thank you very much. See you next time.